of ventilators today. By the 90s, fetal intervention became, and still remains, an interesting topic of discussion. Let's kind of walk through that briefly. So if you look at the fetal repair, Mike Harrison, who trained in LA about 70 years before I did, had an interest in diaphragmatic hernia. He went to San Francisco where they had an established model in the lab, and started with the model that they were working with, and basically developed a field of fetal surgery and the entire field. And his focus was always diaphragmatic hernia. And there's tons of other spin-offs, but his interest was diaphragmatic hernia. And when they got to the point where they were ready to do human trials, they'd done primates, they had to develop a whole series of how to monitor the fetus. They started to enroll patients who were diagnosed before 24 weeks. They were felt to be high risk. We have to define that, I'll talk about in a minute. They had normal chromosome, and they had no cardiac defects. So these are a selected group of the total population of diaphragmatic hernia. First case report was in 1990. A surviving patient who had in utero repair of diaphragmatic hernia. Huge amount of interest in this for a lot of different reasons. And so there became a real focus on maybe we should all start thinking about repairing these things in utero. And this is basically a diagram of some of the techniques, because they had to develop pulse oximeters for the fetus, and a way to monitor their EKG leads and how to avoid labor, and there's just a ton of things. Some of these have not been worked out today. They would do the traditional repair. So they operate here, pull the valve out, and then fix the diaphragm. And then, so the diaphragm closed, and then they put the infant back in and try and carry the pregnancy as long as you could. Problems start to arise, though, and the higher and higher risk the patients are. The bigger the defect, the more likely the liver is to be in the chest. In fact, our current definition of prenatal high risk is liver in the chest. That leads to some real difficult problems in fixing that, especially in the fetus. And by 1993, this paper was published, so just 3 years later. And basically it was, we can't figure out the open repair. We've got too many problems. We're having some fetal demise. The technical problems are very difficult. And basically by 93, this group in San Francisco, which was the only people doing it, said we don't think we can do open repair of diaphragmatic hernia. Right at that time, Jay Wilson in Boston had an interest in diaphragmatic hernia, still does today, and did an animal model. It's one of those interesting things of discovery in the sense that he was copying a paper from a pathology journal, and the back side of the reference on the other side was describing how babies with no larynx who died were born with huge lungs. And he said, well, that's my problem. I need bigger lungs. So they went into an animal model and included the trachea in an animal model. And what they demonstrated was that those lungs would grow, and they would grow dramatically. And if you look at this, the normal lamb's lungs, and this is a lung of a lamb with diaphragmatic hernia, very thick and septate, and they have some other biochemical anomalies. And then the ones who had tracheal ligation looked normal. Not only did they look normal, the first lamb they did, they had no idea about timing, and so they just did it and waited until the lamb was ready to deliver. And the lung got so big it had herniated out of the chest. It was herniating into the abdomen. The lung was so big. So that was an immensely exciting time for us because, geez, okay, maybe this will work. And right at that time, the group in San Francisco had said, well, open repair is not going to work for this. They had and still do a very good primate center. They were ready to just go right immediately into primates. They tried it on several primates and then were able to go immediately into human trials. So this thing caught on very quickly, partly because no solution to the open approach. And their original approach in humans, in the San Francisco group, was to deliver the head, expose the trachea, and put a clip on the trachea. Obviously now the trachea is occluded, so that baby then has to be delivered, and the clip has to be removed. We have to get an airway before we can deliver the baby. Problems. We have a big clip on the trachea. We have trachea problems now as well. And so that was not an optimal solution either. However, they did work on doing, putting a port through the uterus, look into the baby's mouth, and there's these devices that are used for vascular surgery, these kind of balloons you can have, and they're used to, when radiologists, they can come these teeny little balloons and they put them into catheters and they let the balloons go and they occlude things. They just want to clot like a blood vessel tumor or something like that. And so they took one of those balloons and started to apply that. Again, they did it in primates first. Put the balloon in, detach the balloon. So now we don't have to clip the trachea. We don't have to make a big incision in the uterus, which leads to preterm labor. And we can detach and deliver these balloons. Great idea, it still is, frankly. They developed a randomized trial sponsored by the NIH, and they randomized babies to one of two groups. And they have any of these trials of this nature, these high-risk trials, has a data safety monitoring group that always has to look at the data as it's being accrued. And what the data safety monitoring group, when they had accrued this number of patients, 24 total, looked at the data and said we have to stop the trial because there was no difference between the fetal intervention group and the open surgery group. And what had occurred is they had based their sample determination on historical outcomes. And the historical survival outcomes were moving. So the 40% or 30% survival that was historically true in San Francisco in the 80s was no longer the case. And so we were getting better at postnatal management. And so the postnatal patients did better as well. However, in this group, there was a hint that patients, LHR is just looking at the lung and the head and comparing it to in utero. And the smaller the ratio, bigger head, smaller lung, the higher the risk. So they did have a suggestion that was perhaps in a higher risk group. Nonetheless, in the United States, based certainly on this trial, fetal surgery done. Jan de Prest is a gynecologist in Belgium who got real interested in this balloon thing. And so Jan developed this technique of fetal intervention for diaphragmatic hernia by tracheal occlusion. And what they did was they looked at, and continue to isolate the diaphragmatic hernia. Liver's got to be high, but very low LHR, which means a bad risk patient. And they did tracheal occlusion for a couple of weeks. You can't leave the trachea occluded until delivery, because what happens over time is the lungs now don't make surfactant anymore. So it actually has to be on occluded and then on. And they reversed it at 34 weeks at a center, one of three that they went to, and then did conventional neonatal management at the referral center. And they've reported this a couple of years ago now in 2007. And what they have an observed to expected ratio. So their observed survival versus expected. And what they showed was that with tracheal occlusion in the extremely high-risk patients, they had a 25% survival versus basically nil. And then in the what I would call still fairly high-risk patients, a 60% survival. So there's still a lot of interest in this detachable balloon. What they've developed, however, is an ultrasound-guided, very low-risk procedure because it's under local anesthesia. This balloon can be deployed with a single 3mm cannula. And so the surgical intervention risk for the fetus has dropped. It's still fetal intervention. There's still a risk of preterm labor anytime you enter the uterus. So there are some problems with this. And there's a lot of controversy about controls. So the plug procedure, plug the lung until it grows. It really looks